Okay, I guess we can get started because we seem to have more people on. Good morning, everybody. This is Marie Ambrose Big Pen. Thank you for coming to our grand rounds this morning. Can everybody hear me okay?
I can hear you. Thank you.
Awesome, good. Okay. I want to introduce this morning's speaker. It's Dr. Sarah Adams. Dr. Adams comes to us from UNC. She's one of our current hospitalists. She has a degree from the University of Oxford in theological and biblical studies, as well as receiving her medical degree from the University of Oxford. She then did her pediatric residency at the University of Louisville in Kentucky. And she is also a board certified lactation consultant. And today she's going to talk to us about breastfeeding medicine in our pediatric practices. So please welcome Dr. Adams.
Thank you very much. Can everyone hear me okay?
Yes.
Okay, so we're gonna
Yes.
talk about breastfeeding medicine today. It's a real honor to get to be here and talk to you guys, so thank you for having me. Um, and I know that this is a topic that I think a lot of us have very varying levels of comfort with, especially in terms of what we got out of training. I think that varies just a whole lot. So I'm hoping that I have a little bit of something for everybody here, and whether you know a whole lot about the subject or not. So hopefully it'll be interesting for everyone. So just to start with, I don't have any relevant financial relationships to disclose. And I want to give a thank you to Dr. Laskowski, who I work with in a volunteer role from Beaumont Health, who let me use a couple of slides from her presentation. And then you'll also notice on the color scheme that some of these slides have been taken from the speaker's kit from the AAP slides for breastfeeding support and promotion. So the learning objectives today will be to increase familiarity with evidence-based management of frequently encountered breastfeeding problems in term infants. We're going to mostly just focus on the term babies, and we're going to talk about some of the normal hurdles that occur at various points during the normal breastfeeding relationship. We're also going to talk about when supplementation is medically indicated, especially looking at weight loss and jaundice. And then we're going to talk about tongue tie and its effect on breastfeeding and some of the contraindications and some of the things that maybe aren't contraindications but tend to scare or confuse people in terms of whether they are contraindications to breastfeeding. So hopefully we'll fit all that within the hour. So I'm going to start by just very briefly talking about the benefits of breastfeeding. I think a lot of us know already, so I won't waste a lot of your time on this in case this is just review. Really good evidence that shows that there are improved health outcomes for children with breastfeeding of various durations, decreased infections, decreased rates of asthma, obesity, type 1 and 2 diabetes, leukemia, SIDS, and NEC. And for some of these, it's any breastfeeding of any duration that's been shown to improve. Some of them, it's 3 months exclusive breastfeeding, some of it's 4 to 5 months, so the studies have varied a little bit, but the evidence is really clear that this improves child health. Also improves maternal health. We know that it decreases the risk of type 2 diabetes, breast, ovarian cancer, postpartum depression, and it also improves the recovery after birth. So we have decreased bleeding, more rapid uterine involution, decreased blood loss, and increased child spacing with breastfeeding. For a lot of these improved health outcomes for mom and baby, the rates are like you have 50% decrease, 40% decrease. These are significant numbers. So the overall estimation is that if 90% of US families could comply with the medical recommendation to breastfeed exclusively for 6 months, the US would save $13 billion a year and prevent an excess of 911 deaths. And most of those deaths that would be prevented would be infant deaths. So this is a big public health thing, and we can really make a difference in babies and moms' lives if we reach their breastfeeding goals. So I'm going to talk about 3 hurdles of normal breastfeeding that most moms experience. The first one is the first week. Then we have another one at 2 to 3 months, and then we have one whenever mom goes back to work. So the normal first week. First night, usually we have the sleepy baby. After the first few hours of being more alert, baby becomes very sleepy. Mom spends most of the first night trying to wake that baby up to feed it, and baby might be falling asleep at the breast a lot and not feeding that well. Generally, if we don't have any hypoglycemia risk factors, and this is a term infant, I advise the moms not about whether that baby is at the breast and eating every 3 hours. Allow some rest, for mom, and not have her stress just to be then stressed for the opposite reason on night 2. So night 2 or 3, we usually see the cluster feeds. This is where baby's feeding every 30 to 60 minutes for a few hours at a time. There's a really helpful handout that I've linked here for you guys. I think we can help moms and dads so much in giving anticipatory guidance on this happening. Cluster feeding is really good at making a mom feel like, I don't have enough milk, my baby's starving, I gotta give a bottle. And I think it's just so helpful to give some guidance on what the normal expectation would be in this second or third night. We can also help if the cluster feeding is extreme, if we can teach mom how to hand express and spoon feed a little bit of this hand expressed colostrum, that can help babies settle for just a little bit longer and give mom's nipples a little bit of a break. So teaching hand expression, I think this is one of the great toolkits that we have that can really help moms get off to a good start in their breastfeeding journey. In this first week, the focus is really on getting the milk moving. And the pump, while it's good at hormonal stimulation, is not very efficient at removing colostrum from the breast. It's very efficient at removing milk once the milk is in, but this thicker colostrum, most women, when they pump in the first few days, they don't get anything out or they just get a few drops. Hand expression is actually a lot better at getting colostrum out. And we know by evidence that women who hand express 5 times daily for the first 3 days are more likely to continue breastfeeding and also have better milk supply at 6. So this is a really good skill, and I'm going to play this video for you guys. This is a mom being taught how to hand express, and I'm just going to talk you guys through how I usually teach it. So the first thing I actually tell her is to massage her breast a little, tap all over just to kind of wake it up. And then we use a C shape to our hand to hold, not the nipple itself with the of the areola behind the nipple. And then we follow a rhythm that's press back against the chest wall. So the woman is pushing back against her own chest wall and then compressing the tissue behind the nipple and then relaxing. And doing this repeatedly in a rhythm. Tell mom you're not going to necessarily see drops at first, but as you get into this rhythm after the first 30 to 60 seconds, that's when the colostrum is going to start flowing from the breast. Mom can alternate right and left every 30 seconds or so. That kind of mimics some of the hormonal response that moms have to newborn breastfeeding. And you can collect this. I like the little medicine cups. Anything that's small so that the 1 cc that you might get doesn't look too ridiculously tiny is good. And then this can be fed to the baby with spoon feeding, finger feeding, syringe feeding, just to supplement a little bit. And I think it's so encouraging for moms to see the milk, the colostrum coming out of their breasts. So one thing that you tell them when they're pushing back against their chest wall, you don't want them to spread the nipple and traumatize the skin of the nipple. You just want them to push straight back and then compress the tissues and wait until it stops flowing and then relax and repeat. So this link, I actually send parents here all the time. I tell them Google Stanford hand expression. It's a Stanford nursery and it'll show them this video. There's audio as well that explains it and it's really helpful. Okay, so action item number 1 would be to encourage all breastfeeding mothers to hand express 5 times daily in the first 3 days. So taking a look at the AAP recommended breastfeeding practices it's to initiate breastfeeding in the first hour to catch that alert period mom together, which we're really good at doing, avoiding unnecessary suctioning, so that can cause some oral aversion for babies. So I like to teach the parents, if baby's spitting up, you're hearing the baby gagging, sit it up, roll it over on its side. Most babies are really good at clearing those secretions. We don't have to necessarily go in there with the oral suction unless they're really struggling and having difficulty. So all of these things will help baby use its natural instincts to breastfeed. So then we've got night 3, 4, 5, whenever the milk comes in and mom wakes up and the breasts might be engorged. So they're very full, heavy, hot. The skin is shiny, a little bit stretched. They can be so hard that it's actually difficult for the baby to latch. So this is where hand expression can really help, can take a little bit of that pressure off, make the breast softer and allow the baby to latch better, also help mom's comfort. We can use cold compresses if we're having trouble with engorgement, and then a technique called reverse pressure softening, which is basically pressure placed against the tissues around the nipple to just remove some of that edema, to make the tissues around the nipple more pliable so that baby can latch. This handout linked for you as well for your reference. So that's the first week. The next big hurdle in my experience is 2 to 3 months. At this point, we've got a physiological fall of prolactin levels, and the previous oversupply downregulates to matched supply, supply that matches how often the baby is eating. This can lead to a perceived lack of supply. The breasts feel less full, there's less leaking. Baby might be feeding a little bit more frequently again due to a combination of getting a little bit of a less active letdown, so their feed amounts might be slightly less, and they're also just waking up and not sleeping quite as much as newborns at this stage. So all these things can combine to make moms feel like, oh, my milk has gone away, I need to supplement, I don't have enough. We can also see true lack of supply at this point, especially in a baby who's not very efficient at removing milk from the breast. So this might be an example of a baby who has a tongue tie, who's been coasting off of an oversupply and a pretty heavy letdown. So the baby isn't very good at sucking or getting milk out, but it doesn't need to because mom's letdown is really active. So it just lays there and milk flows into its mouth and everything's been fine. But now we're starting to see poor weight gain as mom's supply downregulates. The poor emptying then can result in true poor supply. So we know that when milk stays in the breast, the body starts to produce something called feedback inhibitor of lactation. And this actually tells the body to make less milk. This is how you wean. And so I teach parents about this early on so that they know the importance of pumping or hand expressing to empty the breast if the baby isn't feeding at the breast for a while for one reason or another, because they're getting supplemented or there's a medical reason why they can't feed or they're just super sleepy. So that comes into play here as well. If the breast is being emptied poorly because baby's not efficient at feeding, then that could actually downregulate supply and mom can truly have a poor supply. So these are the two big issues that we see at this age. And then we've got the back to work. So at this point, mom starts pumping, and this is another big hurdle. Many moms don't know what normal production is. They could have normal production of milk and feel like they don't have enough. So normal production is 24 to 30 ounces in 24 hours for the first 6 months. So that's about 3 to 4 ounces every 3 to 4 hours. In breastfed term babies, we don't see the big increase in per feed volume that we do in formula fed babies. So while a formula fed baby at 6 to 9 months might be taking an 8-ounce bottle, very few women have the storage capacity to make 8 ounces per feed. So most babies will feed around 4 ounces per feed, and getting 24 to 30 ounces in 24 hours should lead to good weight gain. So this is about an ounce for every hour that mom is away from the baby and not breastfeeding directly. We can help moms maximize their pumping output by helping them to look for different phalange sizes and shapes, and just different ones work better for different people. And we can also encourage her to pump more frequently. And then there's this thing we talk about called the magic number. So every woman has her own magic number, and it's basically how often you need to pump during a workday to not downregulate your supply. it's going to be a combination of that woman's storage capacity. So how much milk can she pump out at once, no matter how long she's gone since her last feed, and how sensitive she is to this feedback inhibitor of lactation. So some women can store a large amount and make a large amount at once, and they might pump 6 ounces per feed. But they might be very sensitive to feedback inhibitor, so they still need to pump every 4 hours because otherwise their supply goes down. Other women, they're really lucky and they have both and they can just pump. But for most women, they need to pump about every 3 to 4 hours to make about an ounce an hour and to not downregulate supply. And some women might need to pump every 2 to 3 hours to achieve the same result. We can teach caregivers to do paced feeds. I won't show you this video, but this is a helpful video to give to parents. But paced feeds is basically where you hold the bottle more horizontal than vertical. So the baby doesn't have milk just passively flowing into its mouth, but it needs to actually suck the milk out of the bottle. And every couple of minutes, you tilt it down a little bit so that the milk stops flowing, to see if the baby kind of comes forward towards the bottle, sucks a little bit more eagerly to show it's still hungry, and then we give it some more. With these paced feeds, babies are much more likely to take about the same amount as they would at the breast, and us to only have to, the baby would usually get during the hours that mom's gone. We can also help moms know that it's really normal for babies to reverse cycle at this time. So that's when they wake up more during the night when mom's home to feed and eat a little bit less during the day when mom's not there to directly feed. It's normal, although somewhat exhausting. We can also help moms to know their workers' rights. So unfortunately, these only apply to non-exempt employees, so hourly employees. But under the they have to be given both time and space to breastfeed. They don't necessarily need to be paid, but if the employer usually pays for break time, then they need to be paid for this time as well. But they do need to be given a time and a space that's not a bathroom to pump. So how do we assess normal breastfeeding? Feeding observation is one of the really important things in your toolbox to troubleshoot trouble with weight gain or trouble with feeding. So one of the things we want to look for is the latch good? So in this video, this is a really well latched baby. The mouth is wide open. The lips are phalanged outwards, and we can see that baby is slightly off center. So we have more areola visible above the upper lip than below the lower lip. And the baby's head is straight, right? If you've ever tried to drink out of a McDonald's cup with a straw with your head turned, you'll notice it doesn't work very well. You can't swallow very well when your head isn't straight. So we always want to have baby's body aligned, and baby should have a nice full mouth of the breast with a wide open mouth and the lips phalanged outwards. I also gave you guys this video down here. This is not the video that's playing. This is a video that actually teaches parents how to latch, so that can be helpful. You can see here that the nipple in this drawing, it's pulled all the way into the mouth to sit right where the soft palate starts. So the nipple gets compressed between the mid part of the tongue, which comes up in sucking, and the soft palate. And this is why it shouldn't be painful. So if the nipple sits by the hard palate, it gets compressed. So if we have a shallow latch, it's more painful, and the nipple gets traumatized and might look compressed and pointed when the feed is over. When the nipple is drawn further back and sits by the soft palate, it's more protected. However, I do tend to warn the moms, it's a little bit of a lie when we say that breastfeeding shouldn't hurt. For the first 2 or 3 weeks, the initial latch is usually associated with pain for a large number of women. It should resolve. It should last maybe 15 to 30 seconds. I usually tell them it's like, ow, 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 oh, okay, I'm fine. It shouldn't hurt the whole feed. If it hurts the whole feed, we probably have an issue with latch. That little beginning though, I've had women who've been told that it shouldn't hurt at all, and they just latching and think something's wrong with their latch when it's just that normal sensitive first couple of weeks. I do encourage them, it goes away. Women will latch and feed and not have any pain a few weeks on, but initial first 2 weeks can be more painful for the first few seconds. So the second question I ask when I'm looking at a feed is, do we have good transfer? So here I'm looking for audible swallows and visible. So the chin of the baby drops a little wider, stays open a little longer when there's a swallow. So a baby who just has small, fast sucks is trying to achieve a letdown. Once the letdown happens, you should see that chin drop wider, larger sucks, and then hear these little sounds that are the baby swallows. Baby's body should be relaxed, and baby usually would go to sleep after a feed. We would expect a newborn to feed between 8 and 12 times daily, and we would want them to gain between a half and 1 ounce a day. We also think that mom usually would notice that the breasts feel softer and less full after a feed than before. So all those things tell you that we have good transfer. And then the final question is good supply. And really, I want to stress here that the most important question is the baby growing well? If the baby was growing well on exclusive breast milk, there really isn't anything else to worry about in terms of supply. But things that we can look for if that maybe isn't so great is the baby emptying one breast completely before moving on to the next? Does the baby seem satisfied after a meal? And lactation consultants will often use a special lactation scale that's very sensitive to assess the weight before and after a feed. So without changing a diaper or removing any clothes or anything like that, how it is, feed the baby, weigh the baby exactly how it is again. Doesn't matter if it peed or pooped in the meantime, as long as it's all still in the diaper. And that'll help you estimate how much the baby transferred during a breastfeed. We want to be a little careful of sleep training, especially in those first 6 months when the baby is relying exclusively on breast milk. A lot of women's bodies cannot actually go a whole night without emptying the breast without supply down regulating. So even though baby may sleep train and be totally fine and not have any issues with hypoglycemia, it might be that mom's supply down regulates if there isn't any feeding at night. And some women have to pump at night if their baby doesn't want to feed, just to maintain their supply. Not all, but sometimes. It's also normal for supply to vary when menstruation happens, and usually that will regulate itself as long as baby's feeding directly at the breast. So if supply drops because of menstruation or because mom has a little bit of an illness or gets a little dehydrated or anything like that, baby is going to feed more frequently because less is coming out. And when baby feeds more frequently, supply upregulates. So this is the great thing about the feedback cycle. The bad thing about the feedback cycle is we can get into the supplementation cycle. So if mom feels like there's not enough milk, supplements with formula, baby then is overfull, sleeps more, is not at the breast, baby nurses less, and that produces less milk in mom. So we can go around that cycle as well. So that's one of the reasons why we want to make sure to tell moms, if you're feeding a bottle, if you're supplementing, you got to also empty your breasts so that your supply doesn't downregulate. So jaundice and weight loss and supplementation. Formula is a life-saving in moms who do not have enough milk for one reason or another, or babies who can't get that milk out well for one reason or another. So when do we need to use it? So I like to think of the 3 laws of addressing breastfeeding issues. Law number 1 is feed the baby. We don't like starving babies. Law number 2 is protect the supply. So we've got to empty the breast to protect the supply. And number 3 is keep the baby familiar with the breast so that we can work our way back to exclusive breastfeeding at the breast. Some women prefer, more power to them. It's a whole lot of work. I tend to counsel when it's a mom doing it for the first time, let's try to get the baby back to the breast. Let's solve whatever issue it is that's made being directly at the breast harder, because exclusive pumping is just really hard to keep up with. It's a lot of equipment, a lot of washing of bottles, and it's just a lot of work. And you're very tethered to the pump. It's not as portable as just bringing your baby with you wherever you go. Some women maintain this for a year and they're awesome. I think that the rates of exclusive breastfeeding in the longer term are lower in moms who exclusively pump, because it is just a little bit more difficult and less compatible with normal life. So when possible, like to get the babies back. So if you remember these 3 laws, this will buy you time to get more expert help if maybe you're not great at troubleshooting the latch. Not all of us have that skill. And this will give you time and protect the breastfeeding relationship while mom figures the rest out and while lactation consultants come and help in all this. So one is feed the baby, either donor milk or expressed milk or formula. Number two is protect the supply. Empty regularly, stimulate regularly, hand express or pump every 2 to 3, say no more than 1 4-hour stretch overnight for some sleep. And be familiar with the breast. So this could be skin to skin, this could be direct feeding. So if baby cannot tolerate feeds for a medical reason, we can do non-nutritive sucking where mom pumps first and then puts the baby to the breast, and there's not much coming out there. It's not completely NPO. There's always some milk production. We'd have to use a special kind of nipple shield that doesn't let anything through if baby has to actually be NPO. And we can also, in a baby who's feeding but needs supplementation, use a supplemental nursing system. So it's basically kind of like a syringe attached to a tube. The tube gets taped to the nipple, and the baby can get its supplementation actually at the breast to increase the stimulation at the breast. And then also make sure if we're feeding a bottle, we use paced feeding so baby doesn't get flow confusion. So it's probably more flow confusion than nipple confusion. The flow out of a bottle, it just starts right away. It's steady and it's with gravity and it's not that much work. And so that's a lot easier than being at the breast where you have to suck it first without much coming out to stimulate a letdown. And then you have to really transfer that milk out of the breast. So if babies get used to the easy flow of the bottle, it's harder to get back to the breast. So we want to use that paced feeding if we're bottle feeding to prevent that. So action item number 2, apply the 3 laws of breastfeeding issues. 1, feed the baby. 2, protect supply by emptying. And 3, keep the baby familiar with the breast. So let's talk for a second about weight loss. One of the things that we look at is what percentage of birth weight has a baby lost. And we tend to think of 8 to 10% as being maybe a little bit of a warning sign that maybe feeding isn't going that well. I do think that we don't have to supplement reflexively based solely on the percentage of weight loss. And there's this really helpful weight loss calculator here. This actually differentiates between babies born by a C-section and vaginal delivery. And that's helpful because we know that weight loss is greater in C-section due to a combination of more tissue fluid and more retained fluid in the baby, artificially increasing the birth weight. And then also mom's milk tends to come in a little bit slower after C-section. So this gives you percentile curves for weight loss so that you can put it into context of the mode of birth and also the baby's birth weight gestational age to see if the weight loss is abnormal or not. So weight loss is a warning sign, and there should be a feeding observation and evaluation, but it doesn't necessarily have to mean that you definitely have to supplement at a certain percentage. It's pretty common to have inaccurate maternal perception of inadequate milk supply, so it's helpful to gather some more objective evidence than just mom saying, I feel like there's not much in there, I feel like there's not enough milk. So other than our NICU babies, which is a whole different talk, other indications for supplementation are hypoglycemia, although we can also use glucose gel for that and do use that here. Inadequate intake signified by signs of dehydration that are not responding to breastfeeding, weight loss of more than 8 to 10% or more than 75th percentile, unless we feel like the exam and feed observation are really reassuring and we want to give it a little bit more time. And inadequate stooling. So by day 4, we would expect the baby to have 4 stools, and we don't really want to continue seeing meconium by day 5. So the stools should have transitioned by then. If we have breastfeeding jaundice and we can tell via observation or measurements that there's inadequate intake, that is a good reason to supplement. And also in breast is high if we're in the phototherapy land where we're potentially worrying about getting close to that exchange transfusion level, that could be an indication for supplementation at that point. Finally, some women have what we call primary glandular insufficiency. So there's not enough glandular tissue to get full supply. So no matter what they do, how frequently they pump, they're not going to get up to full supply, and supplementation is absolutely necessary in this case. And then some women have intolerable pain, can't tolerate even pumping. So that would be another really good reason to go to a supplement. Okay, so supplementation options, we have hand expression or pumping to get mother's milk. We have donor breast milk, although that's usually only an option in the hospital. It's very expensive to get privately after they go home. And then formula. And we want to make sure that we give an appropriate amount of supplementation. So for the first 24 hours, that would be 2 to 10 mLs. For the next 24 hours, that would be 5 to 15. And for the third, 15 to 30 mLs. And then we go to 1 to 2 ounce. So the supplementation amounts, we don't want them to be too big in those first few days. Otherwise, milk coma doesn't feed for hours, overstretched, might have some spitting up, not helpful. Okay, so I'm going to talk for a second. Sorry, my throat. Okay, so we're going to talk first about anterior tongue tie. Tongue tie, most of us are familiar with this. So this is where the frenulum inserts either right at the tip of the tongue or just behind the tip of the tongue. So this is more anterior than normal, usually results in some tethering of the tongue and difficulty protruding the tongue out of the mouth. We might see a heart shape of the tongue when the baby cries. And then in the class 2, not completely heart shaped, but you can see that divot right at the tip of the tongue there. So in these, very easy fix, the frenulum can just be clipped with some scissors, and we will usually see pretty immediate improvement in breastfeeding behavior. Also important to say that some kids have tongue tie and don't have any issues, but a lot of kids with this kind of tongue tie will have some issues, and clipping it can really prevent some difficulties with breastfeeding. So the bleeding is minimal. It can be done in the nursery or in the office, and usually results with immediate improvement in latch and in tongue mobility. Then we have this thing called posterior tongue tie. So this is a more controversial topic in pediatrics and in lactation and breastfeeding medicine. So I think some of the controversy comes from the fact that a lot of us maybe aren't familiar with exactly what this is. Tie gives this impression that there's something at the back of the tongue that's holding it down, and that is actually not correct. So what posterior tongue tie is talking about is basically a frenulum that is pretty normal in its location of where it attaches, but the length and elasticity is abnormal. So as a result, the mid portion of the tongue is less able to move upward. And as you can see in the latch picture, it's the mid portion of the tongue that moves upward to create the suction. So does this actually exist? Does this actually matter? Does this lead to anything clinical? So unfortunately, we don't have really good evidence on this. There have been studies, but none of them have controls to see whether releasing a posterior tongue tie improves the breastfeeding relationship. The problem with not having controls in these studies is that generally breastfeeding problems improve with time. So it's hard to know if you're seeing improvement with time after this procedure, does that actually follow from the procedure, or would this have happened anyways? I think that we do have a lot of moms that feel like in their personal experience, it was a big difference and in their mind saved their breastfeeding relationship. I tend to think that this probably is real, although maybe in some circles overdiagnosed and in some circles underdiagnosed. But I just want to acknowledge that this is somewhat controversial and the evidence is not really clear on either side here. But to help you understand what people are talking about when they're talking about posterior tongue tie, these are some pictures. So in class 3 here, we have a frenulum that where it inserts doesn't look abnormal. So you cannot diagnose a posterior or class 3/4 tongue tie based only on appearance. But the way to examine is to put 2 fingers on either side of the frenulum and to lift up and stretch side to side and get a feel for how elastic that usually feels, and then how unelastic it feels in these babies. A class 4 doesn't actually have a visible frenulum sail, but it's tissue there and it's just tightly adhered, so the mid portion of the tongue here cannot move up very well. So what we see in babies with this issue is that they have difficulty sustaining suction. You might hear frequent clicking noises at the breast. That's the suction breaking. You might see milk running out of the mouth, not just at the end when baby's sleepy, but the whole feed. The latch might be either shallow or it starts out looking good and it just keeps slipping off despite all of the positioning that you can do to support it. Mom might have ongoing breast pain and we might see poor transfer and poor weight gain, especially at that 2 to 3 months mark when the milk supply, the oversupply downregulates some. We might see poor emptying leading to poor supply. And despite really good lactation consulted intervention and working with positioning and exercise and all this, these things are not improving. I'm going to show you this video here. So like I said, you cannot diagnose based on appearance alone, so video is going to be limited, but you can see how this frenulum is not far forward in terms of where to attach. But as the finger pushes it up, you can see how it blanches. It's white and it's kind of thicker than most frenulums that we see in newborns. So this was a baby who improved significantly after a tongue tie release, even though it's not far forward, but you can see how when it's stretched, it looks a little bit thick and it kind of blanches. It's not very elastic. Okay, so posterior tongue tie release is not, ENT here does a great job with these. But one of the things that's a little bit different in what we tell parents is that we do ask them to do these post-procedure exercises after this. You can see that the wound here has a diamond shape, which kind of shows that we've released all the way to the back. And this wound can adhere back together if the baby isn't stretched. So we tell the moms to stretch after feeds just with the fingers so that it heals well. And the Academy of Breastfeeding Medicine has a protocol with guidelines for the evaluation and management of tongue tie. So I've linked that here for you for some further reading. Okay, so final topic, we're going to talk about a few contraindications to breastfeeding and some that are not. So true contraindications to breastfeeding for infants, the classic one is galactosemia. For moms in the US, it's not recommended with HIV or HTLV, and this is different in developed countries and undeveloped countries. So in a developed country where the formula supply is very secure and the water is very safe, formula is safer than breastfeeding in a mom who has HIV. But in some of the world where those things are not assured, it's considered safer to breastfeed in a mom with HIV. And so you will see this vary geographically if you think on a global level. Also, active HSV lesions at the breast. So if baby would come in contact with active HSV lesions, that's a contraindication. And mom who has active untreated varicella or TB, that is also a contraindication. Moms who are using illicit substances and some rare medications that are actually incompatible with breastfeeding. And we'll talk a little bit more about how to tell whether they are or not. Moms who are receiving antimetabolite or chemotherapeutic agents. So for most of those, you have to stop breastfeeding. And then if you have an active radioisotope scan, there is usually in which you cannot breastfeed, and one specific type of scan cannot breastfeed at all. But other than the active radioisotopes, none of the things that we do in radiology are contraindications to breastfeeding. So I want to plug for a second the Infant Risk app. I don't have any relationships with Infant Risk, but I think this is the best resource if you're looking for a place to look up maternal medications. It's not free, unfortunately. It's like $10. I think it's well worth it. It is a little bit less conservative than some of the other places that will tell moms to pump and dump or not breastfeed for some medications where it's not necessary. So this is out of Texas Tech University. They also have a website with really helpful information and a hotline that you can call to discuss concerns around maternal medications. So this is super helpful and I use it all the time. So wanted to talk for a minute about a few things that are actually not contraindications. So hepatitis B and C in moms, totally fine to breastfeed with. And then in a term infant, CMV in mom is not a contraindication. In some of our preemies, that is more of a concern. So again, this talk is mostly just focusing on term. Mom having a fever or being ill, and then maternal use of either caffeine or tobacco. Same thing with nipple piercing and established breast tattoos. Those are not concerns, although we usually recommend to remove nipple piercings before feeding and also in those initial days when the milk is coming in and engorgement might happen, because it might be difficult to remove after the edema of the tissues sets in. So if it's a well-established nipple piercing where there's no concern about it closing up when you take the piercing out, it shouldn't be a contraindication to breastfeeding, although depending on exactly where those ducts are leaking or some difference in terms of how the milk comes out. Similar with breast augmentation and reduction. So these are not contraindications, but especially breast reduction may affect supply. So depending on what they did surgically with the nipple and whether it got severed from the underlying ducts, that will affect whether or not this causes issues. So we generally watch these moms and babies more carefully for feeding problems, supply problems, and poor weight gain. It's a risk, but there are women who have gone through breast reduction who breastfeed exclusively and have full supply, and it's difficult to predict unless you know exactly what the surgical technique was. And even then, the severed ducts sometimes can grow back together, so it's not an absolute prediction of whether or not there's going to be an issue. So just something to keep an eye on. Pregnancy is not a contraindication. My OB colleagues with breastfeeding medicine interest guidance is as long as there's the concern about preterm labor isn't so high that mom has been told not to orgasm, then it would be okay to breastfeed. The response in the uterus should be similar. General anesthesia, so we'll go into this a little bit more on the next slide as well, but in most cases is not a contraindication and not a requirement to pump and dump. And then adoption. So we actually have moms who adopt, who have not been pregnant, who want to breastfeed. We have really good protocols for how to induce lactation in these moms. Sometimes they get up to full supply, sometimes they get up to partial supply, where there is some supplementation, but they can continue to feed at the breast and enjoy that breastfeeding relationship. And then finally, contrast. So barium and gadolinium, iodinated CT contrast, these are not contraindications to breastfeeding. You can continue breastfeeding, you don't need to pump and dump. And also x-rays do not make the milk radioactive in any way, just not how x-rays work. So for most radiological studies, unless it's a radioactive isotope, we can reassure moms that they can continue breastfeeding and there's no need to pump and dump that milk. So talking for a minute about alcohol, generally alcohol is not a contraindication to breastfeeding. If we think through the amounts of alcohol that are in breast milk, it's pretty reassuring. So the breast milk alcohol level is going to be the same as the blood alcohol level. And as the blood alcohol level rises and falls, the level in the breast milk will rise and fall again. So it's not stored in the breast milk. Once the alcohol is back out of mom's system, it's going to be back out of her stored breast milk in her tissues as well. So if your legal limit to drive is 0.08, that means that the alcohol content in breast milk would be 0.08% at that level. So apple juice, when it's been measured, is between 0.06 and 0.66%, and orange juice is about 0.5%. So even if your blood alcohol level is 0.24, you're pretty impaired at this point. your milk alcohol content is still just 0.24, which is less than orange juice. So we know that alcohol downregulates supply. So if mom's having supply issues, it's probably a bad idea for her to drink alcohol. And also, obviously, binge drinking would raise concerns for the ability to safely care for the infant, safely hold the infant, not fall asleep on top of the infant while you're breastfeeding, that kind of thing. But it's really, that is a bigger concern than the alcohol content in the breast milk itself. So moms do not need to completely abstain from alcohol in order to breastfeed safely, but we do advise against drinking a whole lot of drinks at one time. And this is a really helpful slide from anesthesiology that goes through common anesthetic agents and whether you're okay to breastfeed with them. So the only one that should be avoided in breastfeeding moms, or where you have to avoid breastfeeding after you get it, is meperidine. The other concern is basically morphine, hydromorphone, and ketamine. That does go through to the breast milk. We worry less about it in the first couple of days when mom's making colostrum, and the amounts of colostrum are so small that even though some of whatever opioids mom's getting might go through to the breast milk, the baby's going to get tiny amounts. So in those first couple of days before the milk is in, we worry less. Later, with an established milk supply, it would be better to avoid them or to monitor closely for any signs of sleepiness. We do tend to recommend against codeine, so that's not anesthesia, but just a pain medication, because people are, different metabolizers of codeine. And so if you have a rapid metabolizer mom, her levels could go up fast. You combine that with a rapid metabolizer baby that gets some of that comes through the breast milk. That could be an unsafe combination. But the general take-home point here is that, in principle, once a mom is awake, stable, and alert enough to hold her baby, she is okay to resume breastfeeding and doesn't need to pump and dump after the vast majority of anesthetic agents. So between that and the radiology, we can prevent some of the pumping and dumping advice that gets given out of wanting to be safe, but really isn't necessary and can put a strain on the breastfeeding relationship. So action item number 3 is do not pump and dump for most anesthesia, contrast studies, and x-rays unless we're using radioactive isotopes. So here is a summary of the action items we've talked about. The first one was to teach and encourage hand expression 5 times daily for the first 3 days. The second one is to apply the 3 laws of addressing breastfeeding issues. 1 is feed the baby. 2 is protect supply by regularly emptying the breast, and 3 is to keep the baby familiar with the breast. And action item 3 is do not tell moms to pump and dump for most anesthesia, contrast, and x-rays unless we're using radioactive isotopes. I have several slides here with resources. If anyone is interested in learning more about breastfeeding medicine, I've got some billing and coding resources here for how to get paid for doing this work. Some of these resources are helpful for moms. Some of them are helpful for you. And I want to draw special attention here. Oh. Got a tech issue on the last slide. Okay, special attention here to this Facebook group that's only for physician women, men, called Dr. Milk. It provides evidence-based peer support and education for more than 26,000 members. It was designed to help physician mothers reach their breastfeeding goals, and it's really good in terms of learning more. There's also, and this is for any gender physician, a group called Doctors Practicing Breastfeeding Medicine, or OneTwo, and that's also a really good resource for getting education. And full disclosure, I'm a moderator for the Dr. Milk group. I think it does a really excellent job at supporting physician moms in their breastfeeding journeys. There's also a great website called Kelly Mom, which is patient-facing, has really good information about breastfeeding. And then I have a little bit of a link here in case anyone does want to get trained as a lactation consultant on how you would do that as a physician. So with that, I'm happy to take any questions.
Anybody have any questions?
Dr. Adams, do your own,
Yeah, then that's all.
do you clip your
Okay.
own?
Did anyone catch that? I wasn't able to understand it.
Something about clipping something. Can you ask your question again?
Sure. I'm just wondering, does she do her own frenulectomy, allotomy?
Yeah, I don't. So over at UNC Medical Center, one of our nurse practitioners in the nursery is trained, and she does them in the nursery. And then I usually refer to the Rex ENT office at Cary, Dr. Garside and partners. They have a pediatric speech and language pathologist too, actually, that work with them there. I think they do a really lovely job with before and after care, and also with assessing and not necessarily proceeding with a procedure, just assessing whether it would be helpful.
Thanks.
There was another question as to whether or not the slides can be sent out. And Sarah, do you mind if we send the slides out?
Absolutely.
Great. So we'll send those out to everyone. Are there any other questions? Okay, well, thank you, Sarah. We learned a lot, actually. Thanks for clearing up that posterior tongue tie, because that never made sense when I heard it, but thanks for the graphics and the explanation.
I think it's very unfortunately named. I think that really doesn't help the
Yes.
controversy.
Yep, yeah. Agree.
Marie, we have
All right,
one
well,
other question.
Yep, go ahead.
Trying to locate it now. Sorry. I think it came from, is there any advice for a baby that has swallowed a lot of air, being bloated and gassy?
Yeah. So you talking specifically about like the first week, the first few days in the hospital?
It doesn't say.
Okay.
If you'd like to unmute, he says yes. Sorry.
Okay, yeah, so we do see kind of two main things for why babies maybe in those first couple of days in the hospital aren't really excited about eating. Sometimes they still have a lot of amniotic fluid in their stomach and they're kind of spitting it up and gaggy. That usually resolves over the first 24 to 36 hours. The other one is babies can sometimes swallow air, especially if they're crying a lot. They tend to swallow air when they're crying, and that can then make their belly feel kind of full. Generally, I advise my moms that breastfeeding babies don't necessarily have to burp. So one of the troubles that moms sometimes have is that they're used to needing to burp a baby after every feed for formula-fed babies, and you're trying and trying and trying, and this breastfed baby just won't burp, and that's the opposite problem. But some breastfed babies, they're just very efficient in how they eat, and they might not have a lot of air there to come out. So that's one side. On the other side, if you have a baby who has swallowed a lot of air, obviously keeping the baby upright and helping them burp through jiggles or little pats can really help some of that air come out at the top end. Once the air is starting to move down, and baby might be having a lot of farting and some belly pain with the cramping that comes from gas, the old self-care things like cycling the legs, maybe some Mylicon drops, although I think partially they're probably placebo effect there. But there's no way, it has to come out one way or the other. There's no way, a magic way to get it out. I don't know if anyone's heard of the windy thing. Some of my moms have used that. I'm not sure that's really all that effective, but it's basically like a tiny little rectal tube that you put in to try to get the air out, and it actually makes air comes out. It's amazing what people come up with. I don't recommend it. I think it's probably not particularly harmful, but I don't think there's really any way to increase the speed of getting air out of the gut, unfortunately.
Thank you.
Any other questions?
Any other questions? Okay, well, thank you, everybody. Have a great day.
Thank you. Thanks so much for having me.
Thank you, Sarah.